Aloha and welcome to our series, Nursing and the Human Body. Today we're going to talk about fluid and electrolytes. This is a topic in nursing school that can be a little more challenging, and so we are going to approach it today from a simple frame of mind. We're going to define some terms, we're going to look at some examples, and so let's get to it. We talk about fluids and electrolytes in the body. We talk about the fluids, we're referring to water. But when we talk about the electrolytes, we're talking about a whole bunch of other things. We're talking about sodium, potassium, calcium, magnesium, chloride, bicarbonate, and phosphate. And oftentimes glucose and proteins kind of get tagged on in there as well. And so why is it important? Well, it's important because, like every other system in the body, we're always aiming towards that perfect balance, okay? So growth, energy, and metabolism. We want to balance the growth, energy, and metabolism with our fluid and our electrolytes. Our sugar, we need glucose and sugar for energy. We need salts like our potassium and sodium because they activate so many different things within the body, and the water. And so glucose and sodium and potassium and water require very careful control. And we talk about this term osmolality or osmolarity. This is a way of describing the balance between glucose, salts, and free water. So this is sluggy, okay? And we all know what happens. I mean, if you were a little kid who liked to play with salt and slugs, we all know what happens when we give Sluggy a salt water shower. Okay, when we give Sluggy a salt water shower, it's kind of fun to watch what happens. But why does this happen? Slugs have a thin, permeable skin. So when you sprinkle salt on them, water is rapidly sucked out of their cells via osmosis. And this starts to dry out the slug's body, which in response actually starts producing more slime to try to protect itself, creating the bubbling or frothing effect that makes them look as though they are melting. So kind of thinking about Sluggy and the salt shaker might help us a little bit as we move through this material. So free water is fresh water. Okay. Once we add salt or glucose to that water, it loses some of its freedom and gets stuck to the osmol. Okay. So glucose is really water grabbing. So here we have a U-shaped tube, and it's just got free water in it. Okay. Now we've put a semi-permeable membrane down at the bottom here. And if we get a close-up of that semi-permeable membrane, we can see that only water is allowed to pass freely back and forth. So only water can move freely across the semi-permeable membrane. If we add salt or glucose to one side of the U-shaped tube, this will change the concentration of the water and exert an osmotic pull, changing the water level on the right and left sides of the tube. So let's see what happens here. So glucose gets put in and the water crosses the semi-permeable membrane and it goes and it gets stuck to the glucose molecule. If we pour a 10% glucose solution into one side of the tube and the water from the opposite side gets pulled through the semi-permeable membrane, this happens because it's attracted to the osmol. So this is osmotic pressure. So osmotic pressure pulls water through the semi-permeable membrane, The water is moving from a low solute concentration to a high solute concentration. So why did the water move from the left side of the U-shaped tube to the right? And when will the water stop rising? Once glucose is added, the water can still freely move across the semi-permeable membrane. There's two ways to stop this osmosis. One is a concentration difference disappearing, okay? So the glucose diffuses into the water and equilibrium is achieved. The hydrostatic pressure is another way if it builds and opposes further movement of the water. So two ways that we can stop this osmosis is through equilibrium, when there are equal amounts of glucose all throughout, or the hydrostatic pressure builds and opposes the further movement of the water. So here we can see our example of, we had our U-shaped tube with free water, we added glucose to it, and now we have the water moving to the opposite side, and so we've reached equilibrium. So electrolytes are water grabbing. Let's add salt to one side of the U-shaped tube. Semi-permeable membrane allows only water to pass, not sugar or salt. So if we add salt to one side and we have the water being attracted to the salt, that salt isn't going to be able to move through the semi-permeable membrane via osmosis. The semi-permeable membrane is only going to allow the water to pass. So osmosis and hydrostatic pressure, until equilibrium is achieved or hydrostatic pressure builds and opposes movement of any more water. And that's what's happening in this example. Osmotic pressure is a form of hydrostatic pressure. And the difference is that this measurement quantifies the ability to hold and move water across a semi-permeable membrane. There are semi-permeable membranes in each of these examples. We can see it when we had Sluggy with the salt on him. We could see it in our example with our U-shaped tube. And now we have a body cell here. And so when we look at the body cell, we can see here that we have the extracellular space, all right? And that's the space outside of the cell. And we have the intracellular space, and that's the space inside the cell, okay? And what separates the body cell from the extracellular space is the semi-permeable membrane. And so, again, here's a different example. Here we have an example of a capillary, and we have oxygen-rich blood being exchanged at the capillary level with venous blood. And this happens at the level of the capillaries. And so what we have here in this specialized semi-permeable membrane is a way that oxygen and oxygen-rich blood and venous blood can be exchanged. So what will happen is the oxygen-rich blood will go back up into the heart and be used to perfuse the body, and the venous blood will go back up into the heart and into the lungs to be re-oxygenated in order for it to provide the body with the oxygen-rich blood that it needs. But this happens at the level of a semi-permeable membrane. We talked a little bit ago about hydrostatic pressure being the force of fluid in a compartment pushing against a cell membrane or vessel wall, okay? So whether it's a cell membrane or a vessel wall, we are still dealing with hydrostatic pressure. And so when we talk about systolic blood pressure, the ejection of blood from the left ventricle into the aorta, systemic vascular resistance from the arterial arteries and arterioles, okay? And so at that level of the capillaries, that's kind of what is contributing to this vascular resistance that is so important for us to maintain homeostasis with the blood perfusion in the body. There are specialized semi-permeable membranes in other places throughout the body. For example, in the kidney, we have the epithelial cell in the nephron of the kidney, and we have an exchange that takes place at the capillary bed. And what happens in this example here, let's say we ate lots of spam musubi and we have a lot of salt on board, right? So sodium chloride is table salt. And if we have excess salt, it needs to be excreted into the urine. And so what happens then is that the urine that contains this excess sodium chloride goes into the ureter and it gets excreted out from the body, okay? But semi-permeable membranes are involved in all of these different types of exchanges that occur. So how about diuretics? Lasix and hydrochlorothiazide work by keeping sodium in the urine. And this causes water to follow the sodium, increasing the volume. And so here we can see our cell, we can see the kidney, and we can think about the semi-permeable membrane where the urine is now holding on to, okay, the sodium and in the urine. And so this causes water to follow the sodium, increasing the volume of urine that gets excreted out of the body. So if we have a patient, let's say, who's retaining fluid, like in the case of congestive heart failure, we will give them Lasix, and what it will do is it will cause them to have to urinate frequently, because what they're doing is they're getting rid of excess fluid. Right? So we have to remember that that water is attracted to the sodium, and it will follow the sodium out of the body. So, electrolytes. Let's talk a little bit about them. So, a basic metabolic panel is the lab that will be ordered, and we would be looking at the following labs: the sodium, potassium, chloride, the carbon dioxide, the bicarbonate, the BUN, the creatinine, and the glucose. So creatinine is something that we use to measure our kidney function. It can tell us a little bit about our hydration status. It can also tell us a little bit about the nutrition status. Patients that are malnourished with low muscle mass will tend to have an increased creatinine level. Patients with kidney disease will also have increased creatinine levels. The BUN, or the blood urea nitrogen, these abnormal results can also mean kidney disease and dehydration as well. Too little can be an indication of liver failure or malnutrition. Electrolytes, we talked about bicarbonate in a previous lecture. Chloride, magnesium, phosphorus, potassium, and sodium. Abnormal results of these electrolytes can be a sign of dehydration, kidney disease, heart failure, liver disease, and even tell us that our patient has high blood pressure. We're going to talk about some of these in more detail in a little bit. Calcium, we want to look at the calcium levels, can tell us that we might be having problems with our kidney, our liver, our bone disease, thyroid disease, cancer, and malnutrition. It's important to note that the parathyroid glands can be damaged or removed during thyroid surgery, and this can result in hypocalcemia. Hypocalcemia is a low calcium level, below the normal range. And nurses will monitor for this in the hospital when we're caring for patients who have the parathyroid glands damaged. This is after thyroid surgery. So let's talk a little more about calcium. So low calcium levels can decrease the threshold for activating sodium channels, so decreasing the cell membrane depolarization. So here we have an example of a neuron, and we have a muscle. And what we've got here is the calcium channel, and we've got the low calcium level can decrease the threshold for activating the sodium channels, decreasing cell membrane depolarization. So what's going to happen if we have increased nerve excitability and sustained muscle contraction? This is referred to as tetany. And there are some ways that we can monitor our patients for tetany. This is hypocalcemia, okay? So there are two signs, Chvosek sign and Trousseau sign. One is a more accurate test than the other. So in hypocalcemia, spasms in the hands and fingers can occur when we occlude the brachial or radial artery. And this is one of the signs that tells us the patient is hypocalcemic. Other signs can be numbness and tingling around the mouth or in extremities, paresthesias, which is a feeling of like needles and pins, or dysphagia, which can be difficulty swallowing. So let's talk a little bit about muscle contraction. Some of the players are sodium, potassium, and calcium. And we measure the movement of electrolytes by measuring voltage. So we look at a patient's EKG. What we're looking at is the electrical impulses of the heart tracing. And so in a cardiac muscle cell, potassium imbalances can be lethal. They can lead to lethal arrhythmias. So if we have a potassium level that goes below, I think 3.6, we are kind of in the danger zone. And if we have one that goes below 2.5, then we're really in a dangerous place for a patient to start having an arrhythmia that can be lethal. And so again, we're dealing with a semipermeable membrane here. And in this case, it's the semipermeable membrane of a cardiac cell. And so we kind of look at this schematic and go, okay, yeah, this is how hypokalemia ends up causing problems with cardiac rhythm. And I'm like, it's too much, help, help, it's too much, it's overwhelming. But if we really just focus in on this top part, we can look here and see that when we're hypokalemic, okay, we've got our sodium-potassium pump is inhibited. We have our intracellular sodium overload, intracellular calcium overload, all right? And then what we end up with is inhibition, right, because of the potassium. and we get an action potential duration that is prolonged, okay? So what we're actually looking at this level is that we've got slowing down, right? In hypokalemia, we have this action potential duration, all right, that is prolonged, right? And this can lead to an actual arrhythmia. And this is happening at the cellular level because of a potassium deficiency. So let's talk about what causes electrolyte loss. Well, we mentioned before that taking Lasix will cause you to urinate a lot. So diuretic therapy can cause us to have electrolyte imbalances. And one of the things we worry about with patients who are on Lasix is that we need to monitor their potassium level. Make sure that their potassium level does not go below the normal range. If someone is vomiting, emesis, in vomiting, in NG tube suctioning, right, where we're suctioning the contents of the stomach. In hemodialysis, that's another type of procedure that we would do on our patients that have kidney failure. This also causes electrolyte loss. Even wound drainage, lots of drainage from a wound can actually impact a patient's electrolyte status. So, how do we replace electrolytes? There are a couple ways. We can give a patient IV fluids. We can also encourage our patients to drink more fluids, right? So there's oral intake or there's IV fluids. You know, we need a source of potassium every single day, okay? So if we take a patient and we make them NPO, we might put them on an IV of D5, so dextrose, 5%, that's a little bit of sugar. In normal saline, there's a little bit of salt with 20 milliequivalents of potassium chloride because we need a source of potassium every day. So 1 liter of 5% dextrose in 0.9% normal saline with 20 milliequivalents of potassium chloride. We look at fluid volume homeostasis. We can see here in this example that the blood is about 95% of the fluid. The lungs, they are made up of about 83% of fluid, and the brain, 73%. So we have a lot of fluid volume in the different organs and components of our body. And if we take a test tube sample of our intake and our output, and we kind of look at it from a more scientific point of view, we can see here that the average intake of fluid in a human each day should be around 2,500 or so mLs, right? So we take fluids in through drinking. We take fluids in through our foods and through our metabolism. We actually make fluid. So output in terms of fluid going out of the body, we lose about 1,500 mLs of urine, and that's about 60% of the fluid that goes out of our bodies. We have something called insensible loss of water via the skin and the lungs. This is about 28%. So just breathing, we are breathing out fluid. Sweating, we lose fluid through sweating, and through stool, we lose water as well. So a fluid volume deficit versus dehydration. In a fluid volume deficit, it might be caused by diarrhea, vomiting, polyuria, which is too much urination, or hemorrhage when we're bleeding out. Dehydration is really defined more as the loss of free water without losing the sodium, and so excessive sweating is more likely to cause dehydration. Even though a lot of times we say that a person is dehydrated, Really probably more what's happening is that they're having a fluid volume deficit. So osmolality refers to the concentration of dissolved particles or chemicals and minerals such as sodium and other electrolytes in serum. And this is true for plain old water too. So higher osmolality means more particles dissolved in serum, and lower osmolality means less particles dissolved in serum. So crystalloid IV solutions are solutions containing sodium. We have 3 examples here. We have 3% normal saline. This is a hypertonic solution. We have normal saline, which is 0.9 normal saline. This is a isotonic solution. And half normal saline, or 0.45% normal saline, which is hypotonic. And when would we have a fluid volume deficit that required IV fluid resuscitation? Maybe in the case of diarrhea, excessive vomiting, in the case where a patient is hemorrhaging, they're brought into the ER, and we have lots and lots of fluid going in them via IV. We said polyuria, if a patient is urinating a lot, this can happen in the case of a diabetic. Oh, I've got hemorrhage up there twice, and can lead to shock, right? And so for IV fluids, we'll start with normal saline. When this one is used mostly, this is 0.9. Oftentimes you'll hear people call normal saline 0.9. So if they say normal saline, that's what they're trying to say. It's just 0.9. Used in diarrhea and vomiting when fluids and sodium have been lost. Okay? Can also be used in hypovolemia and shock. And the sodium concentration, or the osmolality, is very similar in this solution to what it is in our own human plasma, right? So this expands our intravascular volume without disturbing our ion concentration or causing large fluid shifts between the intracellular and intravascular and interstitial spaces. But when we have a patient on normal saline, we always have to be careful to monitor for fluid overload, okay? We will make sure that our patient's blood pressure is not increasing. We're going to monitor their intake and output. We want to see whether or not there's any weight gain. And we can monitor their labs by looking for their sodium and their chloride levels, okay? And so we said before that 0.9 was isotonic. We're going to talk a little more about that in a little bit. The half normal saline, or 0.5%, is used as a maintenance IV fluid. It's used to treat hyponatremia. Okay, this is low sodium. It's used to treat dehydration in diabetic ketoacidosis. And so what we've got here is a hypotonic solution. It does contain free water. Okay? And the sodium concentration, or the osmolality, is less than human serum. Okay? If the free water lowers serum osmolality, then the water will be pulled into the cell, causing the cell to swell. And so there's a risk for cerebral edema. So we want to monitor this patient for their sodium level. We want to watch for hypernatremia and mental status changes, okay? So red blood cells in solution. So in this example, we can see that our 3% normal saline, these cells are bathing in a super salty solution, just like the one we poured on Sluggy. And what's happening? What's happening in this case is that all the water is being poured out of the, being pulled out of the cell, right? And what we're ending up with is a cell that is been dehydrated, okay? In the case of our isotonic solution, we have a really nice balance of the water in and out. And in the hypotonic solution, if we put our blood cell just in that 0.45% normal saline, what we can have is too much water ending up inside the cell, and the cell will swell. Okay, so swell up, and so that's the case where we're worried about that cerebral edema, that swelling. Okay, so let's talk a little bit about the fishy tank. We're going to take a normal saltwater fish tank, and we're going to remove half of the water from the tank. And so now what you have is you have a half a tank of water left. Okay, so here's our fish tank. We've poured off some of the salt water, and we've got half of the tank full. Will a sample of this tank water have a higher or lower or same level of sodium compared to the original full tank? Now, if we take a moment to think about this and talk about this, we will find that when the salt water is poured out of the tank, the sodium is lost. And so therefore, a sample of this water will have less sodium than a sample of water from the full tank. Okay? If we have evaporation occurring, okay, so if we have the sun, let's say, shining on the tank, and it's a very, very dry day, and water evaporates, leaving the tank half full, we've got half of the tank full now due to evaporation of the water. So what happens if we allow evaporation of the water, leaving the tank half full? This sample of solution is actually going to have a higher, lower, or same levels of sodium than the original tank. What do you think? If we take water, free water, okay, that's not bound to any salt, and we pour it back into the tank and we fill it up to the top, what are we going to have in this case? Is a sample of solution going to have higher, lower, or same levels of sodium than the original tank? The sodium that was left in the tank before we added the free water will dissolve in the tank, okay? So the osmolality of the solution will decrease. The salt content will actually drop when diluted with the water. And if we look back at these examples, it kind of helps make more sense of that. So again, if we have our blood cell in a really, really salty solution, all that water is going to go out towards the salt. In an isotonic solution, we have a perfect balance. But in a hypotonic solution, what we have is more water migrating into the cell, right? Because we have a solution outside of the cell that is half normal saline. So let's talk a little bit about glucose, okay? Normal glucose is about 70 to 99, all right? And abnormal glucose levels in diabetes, we can have high levels called hyperglycemia, or we can have low levels called hypoglycemia. And we said before that imbalances of water, glucose, sodium, and potassium can be very harmful. So glucose is really water grabbing. And people with diabetes mellitus have elevated glucose, which results in glucose in their urine. I mentioned before that someone with diabetes might urinate a lot. This is called polyuria. And what this causes is water to follow the glucose, increasing the urine volume. Okay? what happens when the blood glucose gets above 400 milligrams per deciliter and glucose gets dumped into the urine? We can see a fluid volume deficit, right? So we said that things that caused fluid volume deficit were diarrhea, vomiting, hemorrhage, and here's that word, polyuria, which is excessive urination. So diabetic ketoacidosis occurs in type 1 and type 2, okay? It happens more in the type 2 diabetic. So we have an example here. We have JP, a 56-year-old male with type 2 diabetes, recently divorced, had a case of the H1N1 flu, drives to the emergency room smelling of booze, incoherent and confused. Your first impression might be that this individual is drunk or on drugs. She's lucky she did not get pulled over and sent to jail for a DUI because what she has is diabetic ketoacidosis. Her blood pressure is 90/50, her pulse is 120, her respirations are 30. Her sodium is 156, so this is elevated. Her potassium is 7.9. Wow, this is elevated. And her bicarb is 5. And so this is lower than the normal range. Her glucose is 850, so normal is around maybe 120. So glucose is very high. And she has serum acetone, okay? So positive acetone and positive urine ketones. So the serum acetone and the urine ketones are positive. So these ketones are acidic byproduct of fat breakdown for energy. They accumulate in the blood and they're excreted in the urine. This is called ketonuria, okay? The glucose is 850, okay? So hyperosmolar leads to osmotic diuresis. Glucose accumulates in the blood, the glucose is excreted in the urine. Water follows the osmol, loss of free water, and some electrolytes in this polyuria. So if we're losing a lot of free water, this is going to lead to dehydration. If untreated, we could end up with profound hypovolemia and shock, okay? So we already see that the blood pressure is low and the pulse is high. So these are some of those early signs. Patient may also have dry mucous membranes. They may be tachycardic and they may be hypotensive like we see in this example. So what do we want to do? We want to give them some normal saline. This is isotonic fluid. It's going to expand their intravascular fluid volume. So that's the volume that is inside their intravascular space. So what does that actually mean? The intravascular space is inside the blood vessel, okay? So here we see an example of this. We see blood cells and we see plasma, okay? So this is our intravascular space where we can have our blood cells and our plasma circulating. And so we want to give this normal saline to expand the fluid volume. Aggressive volume replacement always mandates continuous electrolyte checks, okay? So intracellular space is inside the cell. Okay, the fluid contains mostly sodium. The intravascular blood vessels and space inside, right? The blood cells and the plasma. And then we have this interstitial space. And this is the extracellular space. This is the space outside of the cell. This is where the fluid is that contains our potassium and our sodium and our calcium. Okay? So in diabetic ketoacidosis, we see all these abnormal values. What is the first thing that we really want to think about doing here? What we want to do is we want to lower the glucose, okay? So how can we lower the glucose levels? Well, Again, we've got these specialized semi-permeable membranes everywhere throughout the body, and here we can see example in the capillary where we have too much glucose in the blood. So we can see these little blood cells in our capillary, and we can see that there's too much glucose in the bloodstream. That's why we have a blood sugar of 850, okay? And so the only way we're going to be able to lower the blood sugar is with insulin. We need insulin to unlock the cell so that the glucose can move out of the blood and back into the cells. So most likely this patient will be put on an insulin drip about 10 units per hour, because quick drops in glucose are not safe. We want to have a very gentle correction here. Because if we drop glucose or we drop sodium levels too quickly, we can end up with cerebral edema and coma, okay? So what's our next problem? Our next problem is electrolyte replacement. So we've got a sodium of 156. We've got a potassium of 7.9. Replace them. Why? These are too high. These are too high. Well, remember that she has had much more free water loss than electrolyte loss. So this is why her sodium and potassium levels are elevated, all right? So guess what happens when the volume gets replaced, okay? If we start giving this person a fluid replacement, we are going to have their potassium and their phosphate and their calcium drop like a rock, and this can be lethal. All right. So if this isn't fully understandable, this is kind of why we gave the example of the fish tank, because this is what's actually happening now in the body. Okay, if we take someone who has diabetic ketoacidosis, they've had lots and lots of free water loss, and now we're replacing that, what we can end up with are actual potassium, phosphate, and calcium levels in the blood dropping. So, in diabetic ketoacidosis, boozy breath may be that they're drunk, and this is from the ketones, the acetone, fruity smelling breath. The problem number one is volume, right? So we want to give normal saline to start, and then we might switch over to the half normal saline. We want the glucose correction to be slow and gentle. We want an insulin drip of 10 units per hour. This will feed the cells and stop the ketogenesis. And we want to be able to check those electrolytes hourly and keep a very close monitoring of those. So, we are going to talk more about diabetic ketoacidosis when we meet together as a group. We will have an opportunity for questions, and we'll probably look at some more examples about how fluid and electrolytes work in our bodies. But until then, aloha.